Hello and welcome to my presentation on flank pain assessment and management. We're going to have a look at the patient profile here. So this is a 28-year-old female who presents to the emergency department with bilateral flank pain that's radiating down to her lower pelvic region. She also complains of frequent urination, fevers and nausea. This all started 2 days ago, however has been worsening since this morning. The patient reports that she's had a recent urinary tract infection and she has finished oral antibiotics 2 weeks ago. The patient denies any recent trauma or injury to the flank or lower pelvic region. So history for this patient. She has a past medical history of recurring UTIs that she's had since she was a teenager. She has irregular periods, likely due to being diagnosed with polycystic ovary syndrome. She says she's on no regular medications. She's usually fit and well. She attends gym 3 times a week. She's a non-smoker and rarely drinks. The only notable family medical history that she could provide was her father's has a history of polycystic kidneys. So when she came in, we did a baseline set of vitals on her. It showed that she was febrile at 38.2, which could be a sign of infection. She had an elevated heart rate of 101, which again could be a sign of it being pain-driven or infection-driven. She had an elevated respiratory rate of 24, which also could be a pain response or infection-driven. She had no notable respiratory effort. Her blood pressure was in normal limits, and she was alert and a GCS 15. So based on the information that we have so far about this patient, we're going to do 2 focused assessments. Our focused assessments will be a pain assessment and a abdominal and flank physical assessment. Based on the information that this patient has provided us with so far, we're thinking the most likely body system that we're going to focus on here is the female genitourinary system. So this system consists of all organs involved in reproduction and the formation and elimination of urine. So the ones that focus on the formation and elimination of urine, as you can see here, the kidneys, the ureters, the bladder, and the urethra, and the reproductive organs in this system is the uterus, ovaries, fallopian tube, and vagina. Pain assessment methods. So we're going to conduct 2 different methods of assessing this patient's pain. My reference here asserts that it's using more than one model of assessing pain is best practice, and we all know that sometimes we run into patients that don't display their pain the same as everyone else due to, stoicism or cultural reasons. So what we're going to do for this one is we're going to observe the patient's behavior. How does she look? And then the second method we're going to do is ask the PQRST pain questions in an interview type format. So P standing for provoking factors, like what makes it better or worse, when did it start, that sort of thing. The quality, what type of pain is it? Does it feel like dull, stabbing, shooting, those sorts of things. R stands for radiation and region, like does it move anywhere, as well as any relieving factors. What have you done to help relieve it, and has it worked, sort of thing. And the severity scale is 0 to 10, 0 being no pain at all, and 10 being the worst pain that you've ever experienced. And T is for timing, so when did it start and those sorts of things, and does it come and go in waves, that sort of stuff. So what we learned about the patient from just observing her behaviour, so our first line of pain assessment, the patient does look visibly uncomfortable. She has a lot of facial grimacing. She's guarding her lower abdomen and then also clutching at her flank area, which is suggested that she is in pain. What we learned about the patient from the pain assessment in the PQRST format is that provoking factors is worse after she goes to the toilet, the quality of it, so it's a constant ache with pressure and it feels like she's having intermittent spasms that starts in her flanks, radiates down to her pelvic area, and she's had minimal relief from any paracetamol. That's all she's tried before presenting to the emergency department. And the severity of it, so it's a 4 out of 10 currently just as she stands there, and it's about an 8 out of 10 after she voids. And timing, like she said in her initial presentation, it onsetted yesterday, it's worsening today, and it's quite constant. So now we're going to move on to our physical assessment, which is the lower abdominal and flank assessment. What we're going to do for this is the sort of 3 steps. We're going to observe and inspect, we're going to feel, palpate, and we're going to listen and percuss. So when we were inspecting it, we're looking for any bruising, scarring, distension. What we found when we looked for these things on our particular patient was that she had no bruising, no scarring, and she had a mild distension to the suprapubic/pelvic area. So we started with the least invasive of our physical assessments, which was looking. Now we're going to have a little feel. So what we're going to do when we're palpating here is feeling for any tenderness or bladder distension, which we've already observed. So what we found when we did this with our patient was she had some pelvic tenderness. She was guarding a little bit. The bladder felt quite firmed and a little bit distended. And the patient also complained of increased nausea when we were pressing on her abdomen and when she changed positions. So now that we're moving on to the third and final stage of our physical abdominal and flank assessment is we're going to look at her costovertebral angle percussion. So that's just looking for any CVA tenderness. As you can see by my reference here, so that's when you sort of find where you got the CVA area. We're going to place one hand flat over the region and we're going to tap that flat hand with a closed fist and sort of percuss from there. So doing this action will reveal if there's any CVA tenderness, and that will then provide confirmation that there's likely a kidney inflammation in that area. What we found when we did this to our patient, she definitely didn't like it. She had significant tenderness. We only got started on the left side and she sort of squawked from there and wasn't able to tolerate the full examination. So what we learned about the patient's condition by doing this is likely that pyelonephritis is the source of the presenting problem. Further investigation is obviously required for a formal diagnosis. We can't just go off physical assessment alone. We need some labs to back it up. We have a reference here that sort of states that the presence of fevers, chills, flank pain, nausea, and CVA tenderness would all suggest a diagnosis of pyelonephritis, which she has all of which. So now we're going to move on to our adjunct assessments. After doing our pain assessment and our physical assessment, we are now thinking that she's got pyelonephritis, but as per my reference here, all patients suspected of having pyelonephritis, we should do a clean catch of urine, send some for urinalysis, and send cultures away. What we found when we did this, that her urine dipstick was positive for leukocytes, some hematuria, so she had a bit of blood in her urine, and some nitrates. Also, a incidental finding was her HCG was positive, so she was pregnant and was unaware. Her urine cultures were then sent. Our second little reference here that we have states that in pregnancy, pyelonephritis can lead to significant fetal and maternal complications and needs to be treated early, so it's quite severe. So now that we know that she is HCG positive or she's pregnant, we need to modify to accommodate for this of what our treatment plans and further assessments would be. So first line testing for the most accurate assessment of pyelonephritis would be to do a CT. However, now we know that she's pregnant. That's kind of not appropriate, same as x-rays, because it's just an additional exposure to radiation that isn't good for bub. We need to add on some extra blood tests for her antenatal screening because she wouldn't have seen any of those things as she's had no antenatal care thus far. And we're going to modify what analgesias we give her because NSAIDs wouldn't be appropriate again due to the adverse reflections that it has on bub. We'd have to confirm that the blood in her urine sample is in fact hematuria and not PV bleeding, and we'd also have to confirm pregnancy placement on ultrasound just to rule out any ectopics in case the pain that she has in the pelvic region and this hematuria is we're thinking it's pyelonephritis when it's actually a ectopic pregnancy. So we're going to continue on with those adjunct assessments. We're going to do our blood tests, which include the blood cultures, which will help sort of point us down the right track of which antibiotics we're going to do. We're going to, like we said before, add on those antenatal screening bloods and check her normal electrolytes and just a baseline set of bloods as well. And this sort of outlines as well. So if we were with these blood tests, we're going to be checking for any deterioration of renal function, increased lactate and increased white blood cells sort of furthers the course that if this patient would need admission into the hospital to receive IV antibiotics rather than oral antibiotics and management in the community once her pain's under control. So we're going to continue on with these adjunct assessments. So now that we have decided that we're not going to go ahead and do a CT scan because the risk of radiation would outweigh the risk of what we'd find, we would do a pelvic ultrasound, which is sort of second line in assessing this anyway. This would help us rule out any ectopic pregnancies. It would look for any urinary blockages or stones at this point as well. So putting all this information together, we're going to look at our nursing priorities. Our nursing priorities for this patient so far would be obviously controlling the patient's pain. We know she's in a significant amount of pain, so we want to get some analgesia on board. She is febrile, which we found out early on in the piece, so we're going to get some antipyretics or just some paracetamol at this point if the dosing timings allow it, some antiemetics to help control that nausea that she's been complaining of and just make her a little bit more overall comfortable. We're going to commence some anti-infectives, some antibiotics just to start treating this presentation. We're going to send off a referral for some antenatal care, and we're going to do a post-void bladder scan to check that she is having an appropriate emptying of her bladder. So follow-up plan, we're going to get her to follow up in the community with her GP and hopefully do some early surveillance to monitor for any future infections because addressing it early would be the best course of action. And there is my references.